pathologist who was going to tell us, in this particular case, what's the difference between a severe nephrotic syndrome in an adult and a child. Ladies and gentlemen, I'd like to welcome Dr. Phillip Cheptinga. Thank you.
Thank you for the kind introduction. Good evening, members. I'm going to take you through the treatment of nephrotic children, nephrotic syndrome in pediatric group. I have the advantage of, we have learned the basics of nephrotic syndrome, how to diagnose the nephrotic syndrome, and eventually we have also treated. Let us look at what is unique in the year 2019. This is my city, the Eldoret, which is based in the western part of the country to our visitors. It's our oldest city. It's the city of champions because this is the city where the athletes come from. The one renowned athletes in the world, this is where they come from. This is our hospital. Basically, we have both pediatrics and adult dialysis unit, both hemodialysis and peritoneal. This is the pediatric hospital. It's called SHU for Africa Children's Hospital because it was built by the athletes together with the sports personalities like Ronaldo is part of the team. So you see the field, you'll be able to see the football field for the children, the basketball. We have, the unique thing here is we have classrooms. We have teachers teaching the lower primary and the upper primary, sponsored by the government. This is the new Moi Teaching and Referral Hospital under construction. Most of you might not be aware of that, but it's a 4,000 bed capacity hospital, which is under construction as we speak. And this is how it looks. It's a blocks of 12 units. So we hope in the next 3 or 4 years, we should be able to move in. So as been said earlier on, nephrotic syndrome is a constellation of various conditions, and it's not a disease on its own. Disease might be acute or transient or chronic, and might be relapsing, as we saw earlier on. With us, a prevalence of 1 to 3 per 100,000 children under the age of 16 years, and is best defined as podocytopathy due to the loss or altered function of the podocytes. And studies have shown most of these children, especially to the adults, as they progress to adulthood, they will have reached focal segmental glomerulonephritis, FGS, as you can see. And this, I believe, most adults, they have actually, they are managing condition which started when they were children. So you can have as definition as we have earlier discussed. But in the most recent that it is involvement of the P cell. And this has shown in the use of the Rituximab with the monoclonal antibodies and antibodies in the alternative pathways. And this really, in the recent years, has been the talk and has been the treatment for most of the condition because of the same thought. But remember in the year 2018, what we call there was high circulating level of soluble urokinase receptors in children and adults with FGS. And this has been thought could be one of the factors because when you give immunosuppressants, they tend to go down. Without immunosuppressants, it goes down for almost 16 weeks, which is quite long. So what could this be causing this upregulation of the serum soluble urokinase receptors? What is it really? That when you put the patient on Rituximab, it goes down. And I think this group, we really need to think, what is it? I know this has been studied in a number of other conditions, including tuberculosis and also preeclampsia. And that's been shown it goes up. So what is this underlying factor here? So as said earlier on, pre-steroid era, there were more than 60% mortality. But because of steroid, the mortality has reduced to less than 3%. And this is quite remarkable. Despite the complications of the steroids, we tend to see it's important that we look for options, especially for the frequent relapsing nephrotic syndrome and steroid dependent nephrotic syndrome and resistant type. The critical guideline initially states that recommends the use of steroids at an average of 2 milligrams per kilo up to a maximum, or rather 60 milligrams per meter square up to a maximum of 60 milligrams, and subsequently to be tapered on alternate days and thereafter. If you look at the standard therapy, initial therapy, which was recommended, there were added 10 studies to the 2015 to upgrade the total number to 34, enrolling 3,033 children. And what they said is these studies increase the evidence to the support the administration of prednisolone or increasing the dose during the when the child has upper respiratory infection until when the urinalysis is protein free for at least 5 days. And this really has changed. And I think the most important thing for you and I is how frequent do you track these children? Do you have a chart that when they come to the hospital, you do urinalysis, look for the proteins, come back in the next 3 days, look for the proteins, and then subsequent maybe 1 week or 2 weeks until the protein is negative. And that's the time now you want to taper the prednisolone. In the Cochrane studies, which was shown actually, it's also similarly that steroid therapy for children with infrequent relapses, you give 60 milligrams per meter square until when for at least 6 weeks. And then thereafter you taper and give a lower dose because of the steroid toxicity. And this is what is recommended for the infrequent relapses. This was a study by the Italian Society of Pediatric Nephrology. I borrowed this slide earlier on. The frequent relapses, what option do you do? In our setup, of course, most of the time because of cyclophosphamide in Kenya, it's affordable. We then to give at 750 milligrams per meter square. And subsequently, lamipizole we rarely get. I think it's common in Uganda and some parts of the Sudan. We also recommend, we sometimes a step or a second option for these patients. But we do have that option of calcineurin inhibitors for these particular children. But because most of the time we are not able to monitor the trap level of tacrolimus or cyclosporine, we tend to still have some challenges here. In this corticosteroid immunosuppressive medication for steroid-sensitive nephrotic syndrome in children, which was a review, they found out that it depends on the patient and the physician preference when making a decision. And of course, one of the decisions you make, for example, a patient in Kenya, could be based on the cost and the fact that is this particular molecule available in your locality or not. So these are the alternative therapies. Is congested, sorry members. But remember, cyclophosphamide, you do lamipizole, you have also cyclosporine, tacrolimus, and largely these molecules are available in our country. Prof just mentioned about the Rituximab, and I think the critical guidelines of 2022 for this is an option because of the toxicity of the steroids. And this is what you must, most of the time, you're going to consider. That, is it a first line for you? Is it available? Pre-medication, acute reactions, delayed rejections, and of course, remember the repeat dosing indicators and the long-term safety of concerns, which has been analyzed in this particular study. And the most important one in the dosing is you give at 375 milligrams per meter square, times 2 doses, 14 days apart. You infuse over 8 hours, but in our setup, we also give to prevent anaphylactic reaction we have the protocol for the same. And the same pre-medications and so forth. This steroid-resistant nephrotic syndrome, the critical guidelines partly covers with this what we follow. You give CNI, and of course we suggest this also considered to a minimum of 6 months, then you stop if partial or complete proteinuria is not achieved. And this basically because of the toxicity of CNIs also on the patient. And largely in our country, because we rely on one particular hospital for monitoring the tacrolimus levels, and this is quite expensive also for the patients. So nephrotic syndrome, this is what we have just discussed. So you need to consider the steroids. If it is sensitive, you might want to have infrequent relapse, then maybe long-term remission. If it proceeds, if it's no remission, then you proceed, and you can give alternative low dose and cyclophosphamide as an option. But what one of my teachers at University of Witwatersrand, Professor Thompson, proposed giving very low dose of prednisolone on that baseline, maybe up to a total of 2 months. Other than immunosuppressive management, most important is nutrition for these particular children, physical activity. Don't forget to immunize the children, and of course infections. Albumin, of course, we have protocol for the infusion of the albumin and the Premedication treatment. And last, we all know that on Sunday again, we are going to have another Berlin Marathon, which is coming up. Don't forget to watch. As you watch, remember Eldoret, this is our city. We are the city of the champions. Thank you very much.